Welcome to the start of this year's seminar series. I'm Scott Podolsky, and Salmaan Keshavjee kicked off a wonderful series of talks last year, so it's no accident we asked him to lead off this year's series as well. Salmaan received his master's from the School of Public Health in 1993, his PhD in Psychology and Middle Eastern Studies from Harvard in 1998, MD from Stanford in 2001, before taking his residency and fellowship in social medicine at Brigham in 2005. His impressive includes his 2018 monograph, Blind Spot, critically rating the impact of neoliberalism on global health in the most vulnerable. Salmaan has, of course, been a leader in the actual attempts to reverse and improve such world health outcomes, especially to MDR-TB. He's a scholar, a clinician, advocate, and policy maker. We'll get to hear Salmaan discuss the Zero TB initiative, his biosocial strategy for TB elimination.
Thank you. After that, you're expecting somebody else to get up. Thank you very much. I'm honored, of course, to lead off the series. I'm, of course, to lead off the seminar series this year, and I felt that our group have spent many years working on TB, improve the situation with delivery of care for TB, and so I thought that I would talk about what some of you have been working on. Vis-a-vis pushing for TB elimination. And so, over the next 45 minutes, I just want to lead you through some of the thinking around tuberculosis, and maybe repetitive for some of the people who work in TB all the time. But the idea is just, we're a medicine department, and is there a way that we can use our understanding of history and our understanding of the ecology of policy, really, to help us agenda on giving people better care, and specifically around TB. So just to bring people up to date on the global TB situation. Statistics which really don't vary year by year. There's roughly 10.4 million new cases of TB every year. We find 6 million of them allegedly. So more than 4 million people go undiagnosed. This is an issue because this is an airborne disease. So the people who are undiagnosed and untreated end up transmitting it to other people in their families and communities, and the disease propagates. There are roughly an estimated 600,000 people a year who get forms of the disease that are resistant to the backbone of the treatment. It's called MDR-TB, multi-drug resistant TB, and 8% of those people are treated. So, of course, those strains get spread in the communities where people live and work. 1 million get TB. Only 200,000 of them are diagnosed and hopefully receive treatment. So 2/3 of them do not receive treatment. So every year there's about 2 million people that die from TB. TB globally, the rates of TB have not changed markedly over the last 25 years. The incidence has dropped 1.5% per year, so really very, very low. And TB is the biggest killer of people with HIV. Like, what should the rates be? So the rate's about 120 per 100,000. The U.S. rate right now, this is 2012, I did not take the slide, but the rate is roughly 3 per 100,000. It's about 120 per 100,000. It drops at 1.5% per year. So if you were to try and get the global rate to be the same as the U.S. rate, it would take 200 years at current change rate. See, that doesn't make any sense. And so we think about how do we speed that up. Now, why are we not being able to stop this epidemic globally? This question, I think it's a complex answer to it. I'm going to go into it in depth today, except to focus on, I just want to bring it to your attention. I think that part of it has been, the push in the 1980s, the neoliberal push to reduce the amount of spend on healthcare through the World Bank, just the way we view health delivery as something that people have to pay for. The code words that people use when they're writing about healthcare, they say it should be affordable to the user, which means that whatever the user can pay, they should that's the care they should get. So there's this there's this feeling that, so there's that whole kind of neoliberal piece to it. And then another piece, which I'm working with Aaron Shako and others thinking about, and really the otherness, this othering of people in other countries, really linked to the colonial period, and it's carried itself through to the post-colonial period. And I think the two have kind of elided to give us our policies we have today. But let's focus on one piece of that, because I think that plays a part in our story. They play a part in our story, and I'll come back to both, but focus on the first piece, and that is the focus on cost. Many recall that the Alma Ata Declaration, 1978, that called Health for All by the year 2000. People as a revolutionary moment, because the idea was that even poor, you would have a basic package of health care. A lot of criticisms about Alma Ata. A lot of people said, well, basic package is really basic. It's too basic, and it's similar, but it's almost nothing. But you may be surprised to know that despite that, after people got together and said, wow, promises made in Alma Ata are too much. There's a way that we can do it in the current global crisis, the economic crisis. In the late 1970s, the days of the world were really suffering with inflation and a number of other things after the oil embargo of the early 70s. And so, well, the only way we can afford to do this, we should not do primary health care, but do primary health care. So Ken Warren, who was the head of the Rockefeller Foundation, brought together a group of people at the Rockefeller Foundation retreat in Delaware, the head of the World Bank, the head of UNICEF, and they agreed that they, instead of pushing primary health care, they would push the selective primary health care. And this is a paper that was written in the New England Journal. And it's instructive, because this paper, they said, we're going to focus on diseases that are, very treatable, like diseases, measles, malaria, whooping cough, etc. And we're not going to focus on that are harder to treat, like TB. In fact, the idea, they said, this is like some secret conspiracy. They said, look, we're going to focus on the low-hanging fruit, and things like TB and Chagas disease, they're best dealt with through investment in research. True to some degree, but basically what it did is it brought TB off the agenda of most countries, and it took TB off the agenda of most funding agencies. And TB kind of languished, and then in the late 1990s, 1980s, early 1990s, Chris Murray, who was at Harvard in the early 90s, came with the idea of the disability adjusted life year as a calculation for determining cost effectiveness. And he had been working with Carl Stiebler, one of the kind of like fathers of delivering TB care at low cost in East Africa and other places. And Stiebler had shown him what they'd been doing with TB. And they created a package where they would give 4 drugs, which is what you had to give, and one of them was rifampicin, which is which was a patented drug, but it was off patent by the 80s. And with rifampicin, you could bring down the length of treatment to 6 months. And if you gave it to patients with a community health worker under direct observation, or if you came to a clinic and you gave it under direct observation, you actually deliver care to, you can actually get really high cure rates. The cost of this would not be so high. It was, it really was a awkward moment, because when they did this, Chris Murray was working on with the World Bank on the World Development Report for '93, and they figured out that, wow, if you do this delivery under observation with the short course chemotherapy, you bring down the costs of TB care to a very low amount. And it was very, very didn't involve the health system. It was almost like a vaccination, except it went a little longer. So said, they calculated the cost of this, and said it was very cost effective. In fact, one of the most cost effective interventions that somebody could do in healthcare. And Andy are working on that right now. There's a lot of debate about why it came to the fore and how it came to the fore, but the decision was made that this was going to be a very cost effective intervention. So they worked with the WHO, around making this report and bringing treating TB using well, DOTS, Direct Observed Therapy Short Course, reality. So WHO declared an emergency. They said that there's a TB emergency. At that time, it was 8 to 9 million people that get every year. And then they actually said, and up to 2 billion people are actually infected with the bacteria. And 10% of them are going to reactivate. So it's a global emergency. We have to fix it, and we use DOTS. Now, DOTS was fit well into the selective primary healthcare paradigm. It was really, it fit very because it was simple, it was easy, it was low cost. And the DOTS strategy was very simple. It had 5 big ideas. One was that you had to have political commitment from the government to do this. You had to diagnose using sputum smear microscopy. So sputum smear microscopy was a test for TB that was developed in 1882 by Robert Koch. And it was a way, basically he figured out how to stain slide and look at it under a microscope. And, for a time, it was brilliant. It has a 50% sensitivity. So, at a time when people couldn't diagnose TB, if you could see it half the time, it would be great because then you would be able to identify what bug people had. And it was very simple, and of course you can have a microscope almost anywhere. Part of the strategy was to roll out sputum smear microscopy everywhere. They also were giving the standardized short course chemotherapy, the 4 drugs that I told you about that included rifampicin. The global system, really led by the WHO, promised to make available a regular supply of high-quality drugs, and these would report back with standardized recording and reporting to say how they were doing. And they set goals. You want to treat 70% of the people and get a 70% completion rate or cure rate, et cetera. So that's certain goals. Now, minimalist intervention, because I don't have time to go into the science of TB, but TB is airborne. So they recommended that people go out and look for patients. They said wait for the sick patients to come. It turns out that TB is very slow moving, and people are infected for a long time before they come. And so by the time people would come, they infected their family members. So there was very little focus on transmission or infection control. In fact, there was none. There was none in the 5 things that I showed you. And after there was none. So there was no emphasis on health system strengthening. The idea was to really be minimalist, right? To fit within this select primary healthcare paradigm. Smearcopy allows you to see the bug half the time. So the other, you can't see it. You have an X-ray or some other test, and didn't recommend that. And you can't see if the strains are resistant. And in first drug-resistant strains showed after the first antibiotic was being used in the late 1940s. So DOTS came out in 1993. Drug resistance was a very well-known and well-understood phenomenon. In fact, we had an outbreak of drug-resistant TB in the United States, and pretty much anywhere that anybody checked if there was drug resistance, there was drug resistance. So it basically had this one-size-fits-all type approach. It lacked strategies for active case detection. So normally in a place like the United States, if somebody has TB, you go, you check their household members, you check the places that they work. It didn't have any of that. As I said, it relied on patients to come in. It didn't beat TB infection. So the WHO, in declaring their emergency, said that 2 million people were infected. And the idea would be that if you're a close contact of somebody who has TB and you don't have TB, you would get a prophylactic medicine that would help you not get TB. And it didn't include any of that. It was seen as too complicated. The idea of treating people who had this kind of so-called latent disease, it's not really latent. People who had been infected had been on since the late 1950s. And the WHO had determined in 1962 that it was 1964 that it was too complicated to do in countries because it would cost too much and they didn't have the wherewithal. They brought experts again in 1974 who came to the same conclusion. And the other experts again in 1982 who came to the same conclusion, that it was just too hard for poor countries. A lot of these things that came into DOTS, the decisions about what to leave out and what to leave in, based on science. They were based on can we keep the costs low, would it require developed health systems, or is it something that we could do really easily right now? So those were things really driving the decision making. So it lacked a lot of things. It was a very minimalist intervention, and very dots came out in 1993, right when HIV was running and killing a lot of people in Africa. And people with HIV are only smear positive about 20% of the time. The rest of the time, their smears are negative. So this approach really excluded people with HIV from being treated. Even if he's the biggest killer of people with HIV. And there's people with HIV sometimes higher rates of drug resistance for various reasons, etc. And these people were left out. People who had TB outside of their lungs, and you've probably heard of Pott's disease, where people have it in their spine and they're over, they were left out. It's like one of the highest causes of infertility in the world today is TB of uterus. So people were left out. And left out children, because children have what's called postbacillary disease. They don't make a bacilli, so the smears are only positive about 20% of the time also. So this approach was not a very sound approach. And People's Department, who've been here for the last 20 years, realized that our department and our friends and colleagues, Paul and Jim, took up one piece of this, right? The whole idea of MDR-TB. A lot of us trained, Carol, Mercy, and I, and others, we all trained under Dylan. We all trained under this, to figure out how to get MDR-TB care to happen. The argument was that it was just too expensive. So the whole idea of cost and expense and proving that things were feasible in poor countries were one of the things that we really drove, drove this. And here, consternation. So so how in the system, I think it was around, we were asking ourselves, we started looking at this more carefully in the mid-2000s, and saying, MDR-TB is one of this puzzle, and we were treating people in Russia, and saw that the Russians were doing a lot of other things. They weren't doing MDR-TB. They were doing all these other things that were left out of dots. So we started asking, if we're going to gripe about the rates of TB dropping too slowly, 1.5%, what is achievable? Could we do? And we looked at the example from Alaska in the 1950s. This is Bethel, Alaska. The United States Public Health Service had gone to Bethel, and they found very high rates of TB. It's a very poor part of the country, obviously, and people had living conditions because it's very cold, so people are crowded into houses for large chunks of the year. Nutrition, a lot of things that were very similar to other places. And what the Public Health Service found out was that the rates of TB in Alaska were 2,000 per 100,000. That's 2%. Now, the U.S. rate right now is 3 per 100,000. So very, very big number. 1 in 4 infants in some areas were infected in the first year of life. And they found out that the mortality from TB was 182 per 100,000. So just talking, just in situation. And so what they did is they started building hospitals in the early 1950s. And by 1954, 1955, they started an ambulatory treatment program to treat the active cases. They noticed that after they treated the active cases and screened family members with x-rays, some of these family members would get, so they must have some sort of latent disease that's not on for various reasons. They began a randomized control trial, very large randomized control trial. I can't remember the exact numbers, but I feel like it covered 40 people in total. A randomized control trial to evaluate the use of isoniazid prophylaxis. Isoniazid was a drug that started being used for TB in 1951, and it was found to treat very effectively, except that it didn't use it with other drugs, you got resistance. They said, these guys have active disease. What if we gave them isoniazid for some period? And they tested the periods, but they said, what if we gave them for some period? Would would that prevent them from having this TB turn on? And they gave isoniazid prophylaxis, and they found out that the rates of TB in the intervention group were less than half of the control group to work to stop TB. In fact, when they analyzed their data, they attributed 68% risk reduction to this isoniazid prophylaxis. So an integral part of TB control in the United States. So that they treated active cases, of course, they screened people, and they followed people for about 20 years, and they found out that if you had actually treated them, the people in the as a group, their overall TB rates, probably linked to TB being lower in their community, were lower for 20 years. So this is what happened in Alaska with the program. Rates of TB. This is a marker for the rates of TB. It's not actual rates. It's the annual risk of TB infection amongst children 1 to 3 years old. The idea is that children can only get it from people in their households, get TB from people in their households. So if you see infection going down in children, it's a marker for infection down in the community, and you just see this market drop. This is 1.5% per year, right? So we thought, oh, well, this is interesting. We jumped to New York City. It has an outbreak of MDR TB and regular TB in 1988, and New York, they find that 1 in 5 people have MDR TB, 20%. So it's just this crazy number. And in places like Harlem, rates of TB were between 150 and 200 per 100,000. It's very similar to India. Very, very high rates of TB. New York too. New York set up a system of, they smear microscopy, but they set up a parallel system where they take take sputum and they culture it, which is what people in rich countries have been doing all along. They cultured people's bacteria. They saw what they were resistant to. They got them on the proper treatment. They set up systems of care delivery where they had a lot of poor patients, so they screened those patients. They made sure they got their treatment with community health workers. This is a picture from New Jersey. They had when they screened the cases and their contacts, they put the contacts on prophylaxis therapy. And what happened in New York? You see a massive drop. Again, 1.5% per year. And then here's Singapore in the 2000s, treating TB, and they plateaued out. And they added treatment of contacts with prophylaxis and treatment of active cases, and another drop. And start to see a pattern emerging from all these projects. Russia. I told you we were working in Tomsk, treating people for MDR TB in the prisons and in the community. And our Russian colleagues, it turns out, were doing active case finding, treatment of TB, regular TB, and giving isoniazid prophylaxis. And guess what happened? We started working in Tomsk, the TB rate was 120, and it dropped in half. Again, 1.5% per year. So we did Tomsk method, and we gave patient supports, and we treated all forms of TB, etc. And we worked with our colleagues in another place called Voronezh to TB, and we started around here. And this is what's happened. The rate in Voronezh City dropped from 69. It's now 15. So more than 5% per year. So this is what we realized is possible. I'll tell you about the Russian projects because I know them. They're perfect. If you guys came and evaluated it, you'd say, wow, there's gaping problematic gaps. But they were comprehensive. They covered all the different parts of what you need to do to stop an airborne epidemic. They did perfectly, but comprehensively. And realized, as we started to look at this, all these programs have something in common. And common is that they search actively for patients and they test them properly, using things like smear microscopy. The Russians were like, smear microscopy works half the time. Why would anyone use that? What do you do in the United States? And we said, well, we don't do that. We do X-rays and cultures. And they were like, yeah, that's what we do. So, they search actively, they test properly, they treat effectively. So if somebody has a strain that's resistant, you don't give them short chemotherapy. You give them drugs that work, right? They supported patients through treatment, and they tried to prevent exposure through infection control, something lacking in many parts of Russia, but you're aware of it. And then they treated the exposure, meaning gave prophylaxis to people as appropriate. But all of these places that we looked at were doing that. And so, that this comprehensive approach was, and that it had to be not in a stepwise fashion. You had to view it as what we now call the treatment chakra, a kind of a holistic circle where you couldn't leave one part of it. They all have to happen at the same time. So then, so with this knowledge, we started to rethink the struggle against tuberculosis. How do we do this better? Because we're facing a lot of people concerned about cost, policymakers and donors who will only fund things that are cheap and limited, and yet we know it doesn't work for the disease. And then we're looking at these examples which I've shown you. A couple of them are ours, but many of them are from the 50s. So it's not like these are new findings. So what we did is we gathered people together in June of 2012. We were scared to talk about TB elimination. When we talked about TB elimination, people said, "Oh, you guys, you partners in health guys, or you all farmer followers, you guys are crazy." So we were so scared that we thought, let's be really bold and call for zero TB deaths. Okay. The reason we did that is because in Tomsk, when we started treating people in the prisons, within 2 years we saw the death rate drop to zero. Well, come on, that's low-hanging fruit. That's totally possible, right? So we had a meeting, our TB deaths meeting, and we brought people to Cambridge. And the people that we brought were people makers, practitioners, people from donor agencies that were actually supporting this system that wasn't very well. And we showed them some of these data and said, so what what can we do better? How do we make the system work better? And they, at the end of days of really thinking and talking and breaking into working groups, they said, well, it seems like globally we're not using the right epidemic control strategy. We have a good biological strategy, and we're focusing on just the patient, but patients live in a community, right? Of intervention, by just focusing on the patient isn't right. The household or the community or something. To use the right epidemic control strategy, and you need delivery systems that can actually do this. And right now we're using these vertical delivery systems, and they don't really work very well because patients don't know to go to the TB doctor. They would go to some other doctor, right? Or mother with the child, and they go to a mental health doctor or something. So we think about that. And then we said, well, then why hasn't this happened? Because you guys are the people. Why hasn't it happened if you know this? And well, we have a policy strategy either. We have to figure out how to circumvent bottlenecks in the system, including funding, and work through effective public, private paths. Kind of a nebulous policy advice, but very, interesting. So every year signed something called the Zero TB Declaration. 500 people. So the people at the meeting, which is about 60 or 70 people, and then other practitioners from around the world signed it in their organizations, etc. We felt like, wow, this is not such a far-fetched thing. People do agree with this. How do we actually make this happen? How do we get to the correct biological strategy? Now, I just told you the correct biological strategy, so it wasn't a huge. We didn't search to find out what we needed to do. Around the time we had been sitting, I think Jim Kim was at Dartmouth, and Jim Howard and some of us had met, for talking about how, this is such we need to do, but we're unable to do it. And Jim said, well, we are at one of the oldest universities in the world. Why don't you guys, create a base here that offers a different approach? I think this was in 2008 that Jim said this. And so and this prompted us to do the meeting in 2012. Now we had this outcome, we thought, okay, how do we take this to the next level? And so talking to potential donors and other people, we said, we really want to change the way TB is treated, and we want to do it in a very organized way. And by the time I had this book on neoliberalism, and I was so amazed what the neoliberal thinkers had done. They had met in 1947. They created a template of what they wanted to do. They wanted to infiltrate thought. They were going to go to universities and change the way people learned about economics. They were going to create fellowships. They were going to support book clubs. They were going to give people grants so that their books could be published cheaper. And they did out this whole thing. And they did over the ensuing 50 years. So I wonder if we can learn from them. Could actually try to have some strategy where we the terms of this game. It's going to be hard. We don't have the money that the neoliberals had, because obviously they had large businesses behind them. But could we really do something? And around the same time, a former student of ours that had been in W25 was working for Johnson & Johnson. And she approached us and said, when you used to give lectures on TB, I used to think if there was a way that I could help you change them, I really would. And, we approach you to see if you'd be interested in a grant from us. And I said, well, I want a grant to do this, and I want to change the system, and I want to do this. And she brought one of the presidents of the company in. They said, yep, we'll do that. What's it going to cost? And I said, well, we're going to $3 million. And he said, okay. And I got to go talk to the people you need to talk to and then get back to us. And he said, no, I agree. This is a great thing. Let's do it. So we said, okay, right? Because we went from a situation where we had no money and dreaming of what the neoliberals could do, now having some resources to say, what would we do? And we realized we want to change the biological, the way people are viewing the disease. And when we talked to our colleagues, many people didn't know about the importance of treating TB infection. They didn't know about the importance of infection control. I mean, we were here at the university, but there people were like, no, if you do good dots, you control TB, right? And what we did is we said, why don't we try and get the correct biological strategy out there? We approached our colleagues at the Lancet, and we said, look, we want to do a series on TB, and they said, oh boy, we've done any such things, and we're not super interested in doing another one. What have you to offer? And we said, we have nothing new to offer. In fact, we want to pull together the learning from the 1950s and 60s and really think about how you could apply that today, because that learning has been lost. They're very, very supportive. They said, this could be very interesting. That, if we're saying is true, that we lost this knowledge, and we're saying it, let's try and get this back in the public forum. They supported a series. We have a committee of experts from more than 11 countries. Courtney and Carly were big drivers of it. I don't see them in the room, but they were real drivers of this. We brought a number of people from India and China and other places to be involved in it, and we created a series. We call the series "Getting to Zero TB Deaths," and the Lancet people said, "This isn't to zero. This is about TB elimination." And so they called the series "How to Eliminate Tuberculosis." And what's really interesting is that I just go through what we talked about, because this really lays the foundation of what we were thinking, how we change what we were doing. Was we said you really have to do active case finding, and you have to use your resources properly. Use data for decision making. This idea, if you look at a place like India, when you talk to people, they say, oh yeah, India's rates of drug-resistant TB are 2%, right? And if you talk to somebody from Mumbai, it's 25%. So you put the means that can tell you that you have drug-resistant TB in Mumbai, you don't have it in the backwoods of somewhere that doesn't have it. So you really have to use local data very carefully to target your intervention. And Ted Cohen was here at the time, and it really mapped out, Helen Jenkins had mapped out, a series of countries where, if you actually focused, you could stop the epidemic. And so we had a paper on that. We had a paper on the importance of active case finding. It sounds silly to actually tell people. Some of you have gone to medical school. It's silly because you learn for any disease, but it had to be brought back to the fore of TB. And that if you looked in households, you had TB rates of 1,000 to 5,000 per 100,000, 1 to 5%. Looked at the places where patients sought care, like hospitals and outpatient facilities, 5 to 10%. So really, there were places that you could go and just look for patients. And if you just did that in a place like South Africa or China or India, you would see these massive drops, right? So that was mapped out in these papers. Getting people on the right treatment. DOS wasn't a strategy because it basically gave everybody an empirical treatment. We know what people had, but you assumed that they had a certain strain, and you gave them an empirical regimen blindly, and many of them got better. And Jim and Paul and a lot of our team had fought for in the 90s was to actually see strains people had, resistant strains. And why was this important? Well, it was important so that people don't die, but it turns out it's really important to stop transmission. So this paper talked about, that Ed Nardell and other people also worked on Wiley experiments in those diseases, that you actually treated people, they became more infectious within 24 hours. So really thinking about that part of it, we brought to the fore in the series. The other thing was controlling the seed beds, this kind of treating latent TB. We lay out in this, these arguments that, there's 6 million people with TB, I told you about, right? That we find. One of them are smear positive. The rest are found because they have X-ray or something, or they go to the private sector or something that somebody figures out they have TB, or they have extrapulmonary TB. Go all of our time focusing on this, and it turns out that there's other pot of people that the WHO talked about in 1993, the 2 billion people get an infection. And it turns out that 5 to 10% of them get the disease. So if you don't treat the latent disease and you just focus on this, you're missing a huge, huge pool of people that are contributing to the ongoing epidemic. So we talked about that. And I mean, this was the toughest thing for people to accept. Because people shouldn't treat the people with active disease? Well, the answer is yes. But you also have to treat the people who are infected, because 10% of them are going to get active disease. So, we tried to get across that this idea of latent disease, nothing, is really old-fashioned. And disease occurs on a spectrum. Actually, some people are, disease isn't going to rise up, and some people, somewhere on the spectrum, have mild simmering disease on an ongoing basis. We talked about in this paper, Jason led the paper, we talked about, this weapon in Alaska. Alaska was one piece of information. There were 11 randomized controlled trials looking at giving prophylaxis, and 12 giving prophylaxis to people with HIV and TB, who had been exposed to TB. So there was no dearth of information. So this paper really laid out that argument. And then about the importance of giving patients supports, really trying to change the fact that TB is a disease of poverty, and how you do that. If you look at TB rates in the U.S., they started declining before antibiotics were available. They picked up in the war years, of course. They really have to do with standard of living and access to food and a bunch of other things. And they up in the war years because of standard of living and access to food and things like that. So they started looking at examples of things like Brazil. These are global rates of TB. Brazil, it's dropped 50%. It's about 4.5% per year. Why? Well, it turns out Brazil created a program called Bolsa Familia, which brought 35 million people out of poverty. So we really, in this series said you can't do a biomedical approach. You really have to think about how you're going to help these families with transfers and other things. So really, and we were the only ones thinking this. It turns out that our colleagues from the WHO have written this. They practice within scientific papers showing they've modeled that if you keep doing what we're doing, this is what it looks like. If you just make some risk factors,